A very good morning to you all.
Good morning.
We are all
Morning.
facing a very difficult situation in Nagpur. Every day the cases are rising by 1500, 2000 इस तरह से cases बढ़ रहे हैं and the we all are facing a difficult situation. So we thought that we will go with our series of COVID webinar. Last Sunday, we took the recent guidelines. Before that also, we took one webinar on COVID in which we explained what is COVID and what are the complications and the things we get along with that. This is the third webinar in consecutive series, and today we are very fortunate to have all the known faculties, and we are very fortunate to have Dr. Sharad Jetli from New York. He is also joining today. On behalf of Nagpur IMA, I welcome you all the faculties to this webinar. Also, I welcome all the delegates to this webinar. As you know, people who have a weak immune system are more susceptible to contract coronavirus. We know that people with pre-existing conditions face a higher mortality rate when compared to people affected with no comorbidities. Hypertension, diabetes, obesity, asthma, and cardiovascular diseases are the comorbidities that could aggravate the rate at which coronavirus could affect the body and hamper recovery. Hypertension reduces the immunity of a person significantly. People with type 2 diabetes, uncontrolled sugars are more susceptible to get COVID-19 infection. Poor glycemic levels adversely affect the body's capability to fight off the infection and also causes secondary infection. People with obesity are susceptible to sleep apnea and hypoventilation syndrome. Corona fever can cause myocarditis and manifest as difficulty in breathing, pulmonary edema, and ARDS. Today, we have a galaxy of eminent speakers from various fields, and they will definitely guide us on these important comorbid conditions and COVID-19. A special mention about Dr. Sharad Jetli sir. He is joining from New York. He is a nuclear and non-interventional cardiologist. And sir, we appreciate you for adjusting the timings according to our timings. अभी सर के यहाँ रात के 1 बजे है शायद, और सर हमारे लिए अवेलेबल है. We are very much thankful to you, sir. And I welcome everyone. Today's moderator is Dr. Amol Meshram. He is a consultant physician and intensivist practicing as consultant internist at Janata Hospital, Nagpur, and also he has his own clinic named Siddhar Clinic. He was president of CSI Vidarbha chapter 2019-20. He was past secretary of API 2018-19, past secretary of Diabetic Association of India in 2017-18, past secretary of CSI also, and he is FCCS instructor since 2015. So a very dynamic, young, intelligent, multifaceted personality indeed, Dr. Amol Meshram. Now he will coordinate. He is the moderator of today's CME. So over to you, Amol.
Thank you, madam, for that kind introduction of me. Today, as we all know, India and the whole world is facing this pandemic, and in our parts of the country, we don't see the peak coming, and we are seeing almost more than 40 deaths per day in our part of the city. And we all know the major cause of death in these kind of patients is like delayed presentation and the patients who are having serious comorbidities. So uh, at the outset, I would like to thank our President Archana Kothari Madam, who have thought of such a unique concept in this seminar, because through this seminar, we would like to sensitize our members of our faculty about the management of the comorbid conditions in COVID era. We'll be touching both on in-house and in hospital treatment of these patients. We have the panel of speakers today who will be giving you key points and some highlight some important issues in the management of different comorbid conditions. Without wasting much time, we'll start with our program. And our first speaker today is our very good friend, Dr. Pankaj Harkut. We all know him very well throughout the Nagpur and around Nagpur. He's an intervention cardiologist. He has a very brilliant academic career all over his since MBBS and postgraduate days. He did his MD from GMC Nagpur, DM from Mumbai University. We all know he has multiple national and international awards, and he has been presenting papers all over the world and in India. He has also a lot of publications in national and international journals. Without spending much time, may I request Pankaj to please start his presentation on COVID and heart disease. Over to Pankaj.
Thank you, Amol, for an introduction. So basically, all of us know that we are into pandemic, we are thick into pandemic, and management of cardiovascular disease is important part in managing COVID-19 patient. All of us know that COVID-19 patients, even if we don't touch 80 patients of, means out of 100, if we don't touch 80 patients of COVID-19, we won't do anything. Means rest of the 20%, the patients with comorbidities are the important patient where our skill, our expertise will be needed. And that's why it is important to understand what are the cardiovascular complications and how to manage these patients with cardiovascular comorbidities existing prior to COVID-19. So the management of cardiovascular disease can start from simple aspirin to ECMO therapy. So this is a vast arena, but what we can do in limited resource setting is important. And basically, we have to understand our limitation and we have to design the guidelines in our setting. This is a very seminal paper on the management of cardiovascular disease in resource limited settings. And most of my talk is around this paper only. So till mid-March, I was very much happy and treating in coronary artery disease, but somehow has lost some after the March, and it has all become corona. And I am still missing that ROI in that corona. Ultimately, what we understand over the period of time is that it's ultimately COVID-19 is an endothelial disease. All that is procoagulant state, fibrinolytic state, and inflammatory state, all involving all the organs, including cardiovascular disease. Basically, managing cardiovascular disease in COVID-19 will involve two aspects. One, patient who has already existing comorbidities, and second, the patients of COVID-19 who develop cardiac complication during their course of COVID-19. So these two things we have to understand. The patient who was all right before and develops cardiac complication, the management will be different. Management will be very difficult. Prognosis will be very worse in this patient when COVID-19 patient develop cardiac complication. But what we need to focus is already patients who has already coexisting comorbidities and now develops COVID-19. Here we can save many lives by managing these comorbidities properly. So ultimately, the theme or crux is stitch in time saves 9. So if we can identify this patient before complication occur, if we can manage their comorbidities well, we can definitely save many lives from these comorbidities. So what are the comorbidities we need to manage from cardiovascular perspective? Hypertension is very common, and all of us know that patient who has got hypertension and COVID-19, the mortality is significantly higher. Whether it is an independent hypertension is independent risk factor, or it is because of these patients are elderly and coexisting hypertension, we don't know. But managing hypertension is very important. Secondly, coronary artery disease. This patient can be stable coronary artery disease, post-angioplasty patient, post-bypass patient. So managing this coronary artery disease is very important. And all of us know that because of procoagulant state, because of the platelet activation, cytokine storm, the patients with existing coronary artery disease can develop another attack of acute coronary syndrome during their course. So managing coronary artery disease is very important. Heart failure, these are already precariously placed patient. Any change in their change in their management will throw them to one stage ahead of their heart failure. LV dysfunction, again, we have to identify this patient very well ahead of the complication, and then managing it will be important. So basic crux is that whenever we are managing these comorbidities, important is that already the ongoing medications, already ongoing guidelines, the guidelines which manages these diseases are well in place, and they need to be followed rigorously. There is some tweaks are needed when we manage these patients with COVID-19. Otherwise, the treatment modality, otherwise the all pathways remain same. Coming to second part of second subsets of patient where the management of cardiac complication. If these patients of COVID-19 develops cardiac complication during this course, that myocardial injury, we know that almost 27% of the patients shows raised troponin levels during their course. Acute coronary syndrome with or without ECG changes, this patient can develop just on the basis of troponin positivity. The incidence can be as high as 27%. Heart failure, this patient can develop raised NT-proBNP if we diagnose heart failure only on the biochemical parameter, but they can show florid signs of heart failure during their course. And arrhythmias, again common because these patients are febrile, the electrolyte imbalance is there. So arrhythmias commonly occurs, and then adding to that the pro-arrhythmic drugs like chloroquine and other antibiotics which can induce arrhythmias in this patient. Already these patients are having LV dysfunction. So arrhythmias are very common. Of that, atrial fibrillation is one of the commonest arrhythmias which we see in this patient. So coming to hypertension management, most important thing is here is that don't discontinue the drugs which patient was taking. If patient was already well stabilized on that antihypertensive management, there is no need to change the antihypertensive drugs. Only precaution we have to take here is that the drugs which reduces the plasma volume, like diuretics, need some change. Maybe we can reduce the dose of diuretic in such patients, and otherwise there is no need to change any antihypertensive medication. Discontinuation of antihypertensive treatment may lead to poorer outcome in this patient. And there was initially, from the beginning of this pandemic, there was controversy regarding ACE and ARB, but now we know for certain that ACE and ARBs are far more benefit than harm. There is no need to change the ACE and ARB if a patient is already on these two drugs. Sometimes if patient develop renal failure during the course of the COVID-19, maybe we can reduce the dose, and then we can change to other antihypertensive if required. As we know that patients with heart failure, they can require beta blockers, because that is, heart failure is one of the compelling indications for beta blocker. But here also we should start on short acting beta blocker rather than long acting beta blocker. Otherwise, except these things, diuretics, short acting beta blocker, continuation of ACE inhibitors and ARB, the hypertension recommendations are same. There is no change. But if you discontinue the drugs and patient remain hypertensive during the course, the chances that this patient will have poor outcome. Coming to acute coronary syndrome management, as we know that it is a prothrombotic stage. Already this patient can develop acute coronary syndrome, out of which the few patients may have unstable angina. They need to be managed conservatively. Patients who are having ST elevation MI, we know that ST elevation MI, the standard of treatment is either thrombolysis or primary angioplasty. But here in COVID pandemic, low risk STEMI patient need to be thrombolized as a treatment of choice. There is no question. Because even if cardiac catheterization lab is available, cath lab is available, we should, as a first line of treatment, thrombolysis should be considered. If patient is having high risk STEMI, and cath lab team is available, PP is available, second cath lab is available, so whole team is available, then only we can think of primary PCI. In all other situations, the thrombolysis should be treatment of choice. So this is a paradigm shift in management of STEMI patient. We need to stress on thrombolysis, stabilizing the patient, and if patient is not getting stabilized, then only invasive management will be considered. And non-ST elevation MI, again, conservative treatment takes precedence, followed by, if required, then this patient can be subjected to conventional angiography and subsequent revascularization. Because we know that the patients who underwent revascularization during their COVID treatment, they will have higher chances of thrombosis, higher chances of graft failure, higher chances of stent thrombosis. So better to manage this patient on conservative line of treatment. And if patient is not getting recovered, then we can think of invasive management, because invasive management will risk the operator as well as cath lab personnel as well as whole hospital. Coming to arrhythmia part, sinus tachycardia is the commonest arrhythmia which is present in this patient, and this need to be picked up very early. The patient is asymptomatic, there is no other symptoms are present, but if patient is showing sinus tachycardia, this patient need to be watched very, very carefully. It is the earliest sign that patient may deteriorate further. Atrial fibrillation, as I told, is a commonest arrhythmia observed in patients with cardiovascular morbidity with COVID-19. Almost quarter of patient, 25% of the patient during their course, during their ICU course has shown atrial fibrillation. Management again remains same. Management, we have to start anticoagulation, we have to control the rate. Here the rhythm control is not important, controlling rate and anticoagulation, these are the two treatment of choice. VPCs again are very common. We need to check the electrolytes. We need to adjust the dose of pro-arrhythmic drugs like antibiotics, chloroquine. These need to be adjusted. Ventricular tachycardia again can be observed in this patient if there is already LV dysfunction. Already these patients are cardio compromised, so they can throw off arrhythmias at any point of time. Treatment remains same. If patient with ventricular tachycardia is hemodynamic unstable, DC shock followed by the regular antiarrhythmic treatment. So that's a management of arrhythmia. Here important point is pick up these rhythm changes earlier and treat what is the cause behind that rhythm change is important, and treat that cause rather than just treating the arrhythmia. Cardiac enzymes deserves a special mention because just till the time of pandemic started, we were considering anti-proBNP and HS-troponin. If anti-proBNP is raised, we used to treat that patient as a heart failure. If troponin is raised, that was the sign of acute ischemia. But now just abnormal anti-proBNP and troponin is not sign of heart failure during corona pandemic. We need to, if patient is already a COVID patient and shows up anti-proBNP raised or a troponin raised, that does not mean that that patient is in heart failure or acute MI. That patient, we need to assess that patient. It can be because of cytokine storm, it can be because of various other reasons, myocarditis, all the reasons are there. So just treating the biochemical marker is not important. We have to assess the patient thoroughly and then treat that underlying condition is important. And these two markers, they do not help in the diagnosis, but definitely these two markers help in the triaging of patient. We can very well stratify this patient on the basis of these two markers. So if these two markers are not normal, if they are raised, that means the patient is unstable, patient is high risk, and these patients need to be treated in intensive care unit. So these markers are important in the overall management of disease, but they help in identifying high risk patient. So 6th century proverb was there: when the water is muddy, let stand and let it become clear. Same thing is now become for cardiac marker. If cardiac markers are abnormal, let stand. Don't do anything. Don't jump to any conclusion. Identify the cause and then treat the underlying condition. That's a message here. So just raise anti-proBNP does not always mean heart failure in this patient. It is a prognostic marker, but not a diagnostic marker in this patient. Ultimately, what can I do as a primary care physician, as a treating physician, as a primary care giver? What can I do in case of cardiac comorbidities? First and foremost is do not stop cardiac medication. Cardiac medication is important. We are not treating corona by stopping cardiac medication. These things need to be continued in the background. Some adjustment will definitely be required, but if you stop antiplatelet in a patient of post angioplasty patient may not die of COVID-19, but patient will certainly die of the stent thrombosis. So continuing cardiac medication is very, very important. And with patients with comorbidities, you should have low threshold in getting their cardiac enzymes done. So if patients of LV dysfunction, heart failure, if this patient develops COVID-19, you should get their cardiac enzymes done as a baseline, and that will guide the further treatment. Because if even if there are no symptoms, no sign, and cardiac enzymes are abnormal, these are high-risk patients, and from the day one, they need to be in intensive care monitoring. Otherwise, once they develops the complication and then you start the treatment, you are already lost the battle. Stratify this patient. All patient will not develop complications, so stratifying this patient on the basis of simple cardiac markers, simple physical parameters is very important. That can be done at the initiation of their treatment. Early oxygen therapy, I think other panelists will touch, but we know these patients of cardiac comorbidities are high-risk patients, and the only therapy one of the important therapy which has shown mortality reduction is early oxygen therapy, and that stands true in these high-risk patients also. And ultimately, we have to be compassionate. This is a pandemic. This is a once in a generation, once in a lifetime medical disaster, which all of us are witnessing. So even if I am a cardiologist, I may not treat fever, but here we have to be compassionate. We have to treat these patients as a whole. It is not that I will look after only cardiac comorbidities. I have to treat the patient as a whole. And we cannot, as a medical personnel, we cannot shy away from our duties in this pandemic situation. So these are unusual time. We have to take unusual care of our patient. We have to treat them on telemedicine. We have to take their calls at unusual time, which during normal times we used to shy away. We never have done that. But now we have to be compassionate. We have to understand the situation of the person at other side. So ultimately, message from my side is that don't miss the forest for trees. Yes, we are treating corona patients. We are treating COVID. Don't miss the forest. We have to treat the patient as a whole. We have to treat his comorbidities very well, and then only outcome will be different. Thank you very much. Over to you, Amol.
Thank you, Pankaj. Our plan is to take all the questions at the end. Now, I would like to call upon our next speaker. As we all know, the second important cause of morbidity and mortality in COVID patient is diabetes and other endocrine disorders. We have an esteemed speaker today, Dr. Sunil Ambulkar. As we all know, Dr. Ambulkar very well in this part of the country, but still let me formally introduce him. Dr. Sunil Ambulkar is MBBS, MD, DM in endocrinology, DNB in endocrinology, and he has done MRCP from UK in 2012. He's a HOD of endocrinology in Super Specialty Hospital, Nagpur. He was a past president of Academy of Medical Sciences and Diabetes Association of India. He's a great clinician and a teacher par excellence. I would like to invite Dr. Sunil Ambulkar sir for this lecture. Please share your experience and your wisdom with the crowd, sir. So over to you, Ambulkar sir.
Thank you, everybody. It's great pleasure to be amongst you. I must thank the IMA Nagpur, Dr. Archana, and all the participants today and the delegates for having this interactive session. My topic is diabetes. Diabetes is the most important comorbid conditions in a patient of COVID-19 pandemic. Diabetes can be a diabetes before the onset of the illness, or it can be simply stress-induced hyperglycemia. So diabetes management in the COVID-19 infection, as high as 30 to 40% of adults which are indoor admitted will have hyperglycemia. As I told you, hyperglycemia can be frank diabetes mellitus from the onset of illness, or it can be only a stress-induced hypoglycemia. We have to manage this diabetes optimally in ICU and non-ICU setting as far as the COVID infections are concerned. Why you should treat this? There's a higher rate of hospital complications, especially infection, longer hospital stay, and higher healthcare resource utilization, greater hospital mortality. In obese patient, we have an extreme insulin resistance, and obese are associated with other comorbid conditions that makes a treatment of diabetes a bit difficult in obese patients. What are our aims of treatment? Our aims of treatment are to achieve near normal glucose control without causing hypoglycemia. What are the target blood sugar levels? The fasting should be 120 to 140, post-meal should be 140 to 180. Initially, the targets were lower, and in those patients, the fasting was supposed to be between 80 to 110 and post-meal 110 to 140. But in such subgroup of patients, there were high chances of hypoglycemia and hypoglycemia associated mortality. So the targets which have been prescribed here should be strictly followed. Of course, in a critically ill patient, early insulin therapy is the only choice. Either you give by subcutaneous dose or by an intravenous dose. What is the initial assessment of patient from diabetes point of view? One has to take complete history of the patient and examine him for his other comorbid conditions as well, because diabetes comes as a basket. You do baseline investigations. Glycated hemoglobin A1C will not only tell us how much is the glycemic status of the patient, it will also help us to compare the control, and it will be of prognostic value as well. Do blood sugars, 7-point blood sugar monitoring is very important. Always do kidney function test, especially we have to look for potassium, because IV insulin therapy and insulin IV fluids, the tendency of hypoglycemia is much more high, and we have to correct it in time. Look for ketones in urine or serum, do an EBG, especially if you are suspecting diabetic ketoacidosis and hypoglycemic hyperosmolar state. Of course, you have to do ECG and baseline X-ray, chest and screening for infections. Liver function test, other specific markers related to COVID infections are absolutely essential. So we should be in a stepwise approach for sugar management. At the onset, if the glycated hemoglobin A1C is more than 9, or random blood sugar is more than 180, or for that matter 200, those patients having a tendency towards hypoglycemia, you start insulin either in a subcutaneously fashion, in multiple dose insulin therapy, or conventional therapy, or IV insulin therapy. If the blood sugars are glycated hemoglobin is less than 9, or random blood sugar less than 180, we can start with the oral hypoglycemic agent, ensure adequate calorie intake. One has to specifically ask patient to have one citrus fruit and milk at night. That will avoid nighttime hypoglycemia. Very, very important to avoid nighttime hypoglycemia. Daytime hypoglycemia can be detected and treated as early as possible. So what are the indications of IV insulin therapy in a COVID-19 patient? The starting blood sugars are very high. For example, say more than 400. If the patient is nil by mouth status for any reason, of course, in a patient of DKA, hyperglycemic hyperosmolar state, myocardial infarction, shock, or severe infections, glucose exacerbated by high dose of steroid, these patients are either on conventional methylprednisolone, 40 milligram BD, or sometimes they are on high dose of methylprednisolone. This steroid therapy exacerbates diabetes by increasing insulin resistance, and they might require insulin 3 to 4 times than their normal requirement, or maybe insulin therapy. We have to have separate IV insulin line, 50 units of insulin in 50 line, maintain hydration. If there are no contraindications, 100 ml normal saline per hour. As I said, potassium measure every 8 to 12 hours. In fact, their requirement of potassium can go as high as 3 to 5 milliequivalent per kg body weight. Monitor blood sugars while on IV insulin therapy at least 1 or 2 hours. Of course, you should watch for hypoglycemia. IV insulin protocols are too much, but this is one of the simplest protocols. You follow these protocols as per your blood sugars and start insulin therapy. Check blood sugars. If the blood sugars are less than 150, stop infusion protocol, IV insulin infusion for 1 hour, recheck sugar and decide accordingly. We have to, if the patient is stable enough and the patient has inadequate oral intake, then you can think of giving subcutaneous insulin therapy. Subcutaneous insulin therapy can be in a form of basal bolus multiple dose insulin therapy, or it can be a conventional insulin therapy. The basal bolus dose insulin therapy tries to mimic pancreatic beta cell insulin secretion. Pancreas secretes basal insulin in a pulsatile fashion, and it amounts to 50% of insulin secretion by pancreas. 50% of pancreas secretion comes into bolus with breakfast, lunch, and dinner. We are trying to mimic nature by giving basal bolus regimen. So basal, you can start with NPH, you can start with glargine or Levemir. The starting dose of basal would be 0.2 unit per kg body weight given at bedtime. Then you titrate as per the fasting glucose. The bolus can be, it can be regular insulin, or it can be insulin analogs like Lispro and Aspart, given with breakfast, lunch, and dinner. The starting dose here again is 0.2 units. This is in general. So the patient has got infection, patient has got obesity, patient is on steroid, then the insulin doses will increase accordingly. This is a good therapy, but if the patient is really stable, his diet is okay, he has no problems with his physical activities, then a conventional insulin therapy with a mixed 50-50 insulin is also a good choice. We have to start the insulin dose. For example, the patient's body weight is 60 kgs, then the starting dose would be 60 divided by 2, that is 30 units. You do 2/3 before lunch and 1/3 before dinner. Or you can 2/3 with breakfast and 1/3 before dinner and titrate according to the blood sugars. You can always add a regular insulin at lunch. So mix 50-50 with breakfast, mix 50-50 with dinner, and regular with lunch is also a very good idea. In fact, I have a better experience while managing with this kind of treatment where the insulin requirement really go high. What is the role of oral anti-diabetic drugs? We have to avoid certain drugs. For example, metformin. Metformin is not indicated when patient has got nausea, infection, dehydration. They may precipitate lactic acidosis. One has to avoid SGLT2 inhibitors and glitazones. They can alter the fluid balance. SGLT2 inhibitors, if the patient has got infection, stress, they might precipitate euglycemic decay. To have considered sulfonylurea. Third generation sulfonylurea like glimepiride and glycosides. Glimepiride, the usual dose is 2 to 8 milligram, but optimum 4 milligram in divided dose is good enough. Glycoside, 60 to 320 milligrams, but the optimum dose of 160 is good enough. You can use gliptins. You have to avoid glibenclamide, especially if the age is more than 60 and creatinine is more than 1.5 or 2, because it has got a half-life of 9 hours, and it can cause hypoglycemia in a susceptible population. So glimepiride and gliclazide are two beta sulfonylureas. If you have to look at your postprandial blood sugars, if they are high, then ripaglinide, acarbose or voglibose in with breakfast and lunch, dinner, BD or TDS doses can also be used. So diabetes management in the COVID patient in nutshell would be sugar monitoring protocol you have to follow. In a stable, fasting post-meal, pre and post-dinner is good enough. In an unstable patient, 7-point testing protocol is important. Fasting 2 hours and post-breakfast, pre-lunch and post-lunch, pre-dinner and post-dinner, and 3 a.m. The 3 a.m. blood sugar is important. If your 3 a.m. blood sugar is more than 70 towards 100, you will practically never develop nighttime dangerous hypoglycemia. As I said, you should ask your patient to eat an apple and take a cup of milk when he goes for sleep. That will also help in avoiding nocturnal hypoglycemia. Critically ill patient require IV insulin, IV normal saline. Then they can be shifted to subcutaneous insulin, or they can be discharged on oral hypoglycemic agent as well. Monitoring of potassium is important. Watching for hypoglycemia is important. Informing and treating and adjusting the next dose of insulin or oral anti-diabetic drug is also important. In some patients, if the patient is affording and patient is critically ill, we can have continuous glucose monitoring system today. We can measure the blood sugars practically every 5 minutes by this instrument, but this is a cost, is a prohibiting factor. Of course, we have to provide the diet chart in the regional language and Hindi, and they should be vigorously followed by the patients and the relatives of the patient alike. A word about the endocrine disorders with COVID-19 infections. Thyroid disorders are common. Hypo is more common than thyrotoxicosis. Interpretation of TFT becomes tricky when the patient has got infection, stress. You have to do free T3 and free T4 and TSH. Patient will have presentation like CQ thyroid syndrome, infection, steroids, beta blockers, heparin. They can cause low T3, low T4, low TSH variants of CQ thyroid syndrome. On recovery, you will have a variant of high levels of T4 ECQ thyroid syndrome. But during the pandemic and during the infection, you measure thyroid functions by doing free T3 and free T4 and TSH rather than total. Any infection can precipitate thyroid storm, a medical storm, so you have to manage thyrotoxicosis vigorously. The dose of hypothyroidism is 1.62 microgram per kg body weight on empty stomach. And do not ask to take anything, coffee, milk, or breakfast immediately, because food can interfere in the absorption of thyroxine by 40%. Adrenal gland disorders. Of course, the dose of steroid will increase. If the adrenal insufficiency is there, you might require 100 milligram of hydrocortisone 8 hourly. With steroids, maybe with methylprednisolone or dexa, dose of insulin can triple or they can go more. If the unfortunate patient has got hypoparathyroidism, so during infection, the dose of calcium and vitamin D will increase. You have to give 125 dihydroxyvitamin D, calcitriol, and at least 1 to 1.5, 1000 to 1500 milligrams of calcium during stress period. They require high calcium and vitamin D during stress period. So this is in nutshell about endocrine disorders. I thank you for your present hearing and will be willing to answer your questions at the end. Thanks, everybody.
Thank you, Ambulkar sir. It was indeed a fantastic presentation. We'll be, as you said, we'll be taking all the questions at the end of the session. I'll be taking questions on the behalf of the participants also. So coming to our next speaker. So may I, first of all, my sincere thanks to Dr. Sharat Jetli. I know it is almost 1:30 a.m. in the morning at New York, and he's up and bright, as you can see his face, and he's very excited to share his experiences. He'll be speaking on the current perspective of impact of COVID in cardiac conditions, challenges, and changing strategies in the US. He's MD, he's an alumni of Nagpur GMC. He's an American board certified in internal medicine, cardiology, and nuclear cardiology. He's a director of cardiology and consultant at Calvary Hospital, Bronx, New York since 1988. Dr. Jetli, may I request you to share your views regarding your topic. Dr. Jekyll, please.
Thank you for having me over. Can everybody hear me?
Yes, sir.
sir.
I wasn't sure. I haven't tested myself the last few seconds. Yes, it's past 1:50 a.m. and on my second bottle of water, trying to stay awake. And of course, thank you all for having me over on this seminar. I really, really appreciate this because one, I'm able to join with all of my good friends, and two, I'm closer to Nagpur now, not only from my heart, but also via this wonderful virtual space that we are connected with. So Nagpur has a very, very special corner for me. One, it's my hometown. Two, my alma, and three, my family lives there still. So we are very, very, connected, and I tend to visit quite often. I would like to thank Dr. Archana and Dr. Sachin, who have really, made it possible for me to be connected here because in the heart of the hearts, I was personally feeling why Nagpur is suddenly taking a trajectory so steeply, like it was mentioned earlier by Archana, that it has now climbed to the second or third position in the Maharashtra state. And that is worrisome because we need to know why one city is performing in a more hotter spot rather than the other. In fact, as you all know, that New York was the epicenter after Europe had been the epicenter following Wuhan. So, and New York currently has now in the past couple of months, as you all know, is barely reporting only about a case or two in the entire week. So in fact, now we don't even have COVID patients in any of the hospitals, which is the good news from this part of the world. And so there has been failures, there has been successes, there have been some lessons we all have learned. And as somebody would say that, somebody, of course, very prominent person who said that was, we know that necessity has been the mother of all inventions, but I say something different. I say failures are the more the failures, that's the father or the parent of all successes. So I see that my screen is now showing Dr. Amol Meshram on the top. And how does that work with, because I do not have slides, I'm going to be only talking. I do not show PowerPoints on webinars as a practice. Anyway, so I thank you all. And before I begin my brief talk, I know it's a very vast subject. Pankaj has already alluded to most of the cardiovascular conditions. I do want to dedicate as I've always done, dedicate my discussion or any webinar wherever I begin to my dad, who was an educationist, and my son, who is an entrepreneur and is absolutely an visionist in my life. And my dad shaped me to be a doctor, and my son has shaped me to into a retirement phase, if you will, now with my munimeterhealth.com, which is a teaching website. And I think many of you already know. If others don't know, they can kindly note it. We have a presence in over 85 countries now, and quite a few thousand people are following all over the world. And we are probably, my son and I, we are very proud to say that we are the premium world channel in cardiology, both in English and Hindi, and I proudly say that. And we've tried to cover most of the video chapters in short periods of time in cardiology and in heart. So Hindi may be here or English may be here, dono mein hai. And munimeterhealth.com, you can kindly follow that. Now, without any further ado, as I always say, let's delve into the matter. Let's delve into the heart of the matter. But in this context, in this webinar, I'd like to say, let's delve into the matter of the heart, if you will. And that's what we are discussing. So how does the current perspectives impact in the setting of this COVID pandemic, which has fallen from the sky, looks like, into this planet, and now is engulfing every single nation. Almost 215 nations, as you know, have been engulfed with this in a matter of just 9 months. All it began was January, and look where we are in September now. 215 countries are involved. We have cardiovascular problems, we have diabetes problems, we have respiratory problems, we have endocrine problems, and we have even hematological and coagulative problems because of COVID. So COVID is not anymore, friends, a respiratory illness. COVID has been defined as a totally unique problem. If you look at SARS-1, which originated in 2002 historically, that was also originating from China, by the way. And that actually caused a 10% mortality, 800 deaths out of 8,000 people. But that had a special affinity only to one receptor, and that was the ACE2 receptor. COVID, which is the SARS-CoV-2, and henceforth we'll be referring to easily saying COVID. The COVID virus has an affinity, dual affinity. It has an ACE2, and there is also a TSRMP protease. It's called tetramerase protease, if you will. And that is actually also responsible for multi-system involvement, if you will. So it is beyond the lungs. And that is one of the problems that I think all of us are here together wanting to share our opinions. And the whole idea is wanting to see how best a general practitioner, a general physician, and the specialists, all of us, we are, like Pankaj said, that at this point, we are not even specialists. We are all basic doctors first. And that is so important for us to really go back and see how best we can actually treat our patients by knowing what exactly is going on in each one of them. So it's very important to know where the port of entry is for this COVID virus before we know how it attacks the heart. So very briefly, as I said, it enters the cell through the ACE receptor. And once it enters the cell into the ACE receptor, what it does is it breaks open the cell. And that's where the microscopic cytokine storm begins. We don't even see that in the patient yet. But all it has happened is intracellularly, that cell is broken loose. As a result, those cytokines will be released into the bloodstream, and then they will be detected over a period of time. We know that. But by then, the disease has already spread to the organ. So it's very imperative for us to see this condition as a very serious problem. And we know almost up to 50%, according to Dr. Fauci. I was listening to him yesterday, as a matter of fact, which was here Sunday morning beginning, and Saturday morning, he delivered a talk at Mass General Hospital, and it was a webinar just like us. And he was, he was coordinating at the Mass General Hospital. And he said, it's very worrisome that 40 to 50% of the COVID patients are asymptomatic. And because they are asymptomatic, he calls them asymptomatic transmitters. Because they are going around, they are partying all around, they are talking to people, they are singing, they are sneezing, they are in the elevators, they are with you. And we do not know, and some of these patients could be still transmitting, and that's what keeps this pandemic going from one region to the other. The United States has now has shifted the hotspots to the 36 states literally at the bottom of the map, if you see, mostly on the West Coast and then into the southern states. So there is some predilection that's happening there as a result, which has now moved the hotspots instead of the northern states where we are in New York, Massachusetts, and others. So I'm just trying to compare how and why all of this is going on. Likewise, it's a similar situation. We should start thinking why Nagpur has, which was staggeringly low, about 11th or 12th in the entire pandemic, if you were to follow, and that gave us a sense of relief. But somewhere something went wrong that it's climbed up to the second or third position. Not that the ACE2 receptors have become active, not that the cells are suddenly breaking loose, not that the physicians are not responding to their patients, but there have been some breach someplace which has occurred, which has caused this hotspot to occur. Now, that is a whole different subject to talk about, but it's about time that we start thinking so that this way we can start analyzing and make sure we address every single block as we go along. Coming to the cardiovascular injury that first occurs, it was already pointed out by Pankaj that the troponins will start to release once the cardiomyocyte that cell is ruptured. Because once the cell ruptures, troponin leaks into the bloodstream, period. And high sensitive now, we have the high sensitive troponins, the HSTS, HSTP, those are highly sensitive. You can actually detect them at a very early stage. Now that implies only myocardial injury, period. Does not imply anything else. It does not mean somebody's having a heart attack. It does not mean somebody's already ready to develop a heart failure, but it's a telltale sign that this is what's going to happen and the cytokine storm has begun in the heart. And that's what we are talking about today. We are talking not only in the heart, we're talking the vascular system. Importantly, ACE2 receptors, just for your good news, are present in the entire endothelial system. It's a commonly asked question by me to all my students. I always say one thing, which is the largest organ in the body? Invariably, all the medical students point to the liver. They say that this is the largest organ. I said, you're right. It's the largest organ which is physically present within the body. But what is the largest organ? The largest organ is the endothelial system, my friends. And that is lining 90 to 110 miles, depending upon the height of the person, throughout the vasculature, throughout the vascular system from head to toe. You can imagine every single capillary is being lined by endothelial cells. And every endothelial cell has that ACE2 receptor. Don't ask me why ACE2 receptors are involved in this, but that's where this virus, this guy likes to get in from. It goes and docks into the ACE2 receptor, and next thing you know is it's starting to work inside and breaks it open, and that's where the problems arise. The cytokine storm begins. So importantly, we have understood so far is how the vascular injury occurs, where the entry occurs, and now we need to know what it does once it goes to the cardiomyocyte. Once it goes to the cardiomyocyte, what happens is the first thing is the inflammation. The body tends to react. And inflammation always ends with an itis, so it's called myocarditis. So myocarditis, the signs and symptoms may not appear, but the myocardium is starting to show some inflammation microscopically or macroscopically, what have you. And by the time it shows macroscopically, things are turning a little different. You could see LV segmental. I'm a non-interventional cardiologist, so and we have to dedicate an echo, which is only for COVID patients on those COVID units. So it's very, very important for us to understand that you can't walk around with that portable echo into COVID to non-COVID floors. So that echo machine has to be, the doctor has to be by the bedside or by only in the COVID units, and that's the recommendation made by the guidelines. So it's crucial for us that we understand that the segmental wall motion abnormalities may be the first sign that one could see. And these are asymptomatic LV dysfunctions right now that are occurring. We don't even have a heart failure setting yet. Next thing is, of course, the heart failure setting occurs where the LV dysfunction, the LVEF goes down, and that's where all the support begins. Once you have that, that's a big issue. Now, why does a person become hypoxic and yet have clear lungs? That will be discussed, I'm sure, by the subsequent speaker. But one of the problems here is that this is what is happening. The LV dysfunction that's occurring, patients are starting to show a VQ mismatch, if you will, in a way where certain alveoli, they are being ventilated, but they are not being perfused, and vice versa. So it's almost akin to like a pulmonary embolism. That brings us to another area where COVID virus now also is procoagulated, very importantly. It activates a complement cascade system, and it also activates the coagulation system. And the two will crosstalk together, and as a result, one can develop procoagulopathies. In fact, they are now called complementopathies, if you will. So understanding the cardiovascular system in a way how COVID gets to impact is so important for us, and then manifest that in the clinical way is we are only able to know that in these 8 to 9 months, that now it can manifest as myocarditis, it can manifest as heart failure, it can even cause myocardial injury, mimics somehow acute coronary syndrome. Now, it's very important for us to know that patients, by the way, there was an article in the New England Journal of Medicine by Dr. Mehra and from Boston Group, and they revealed that patients who are on ACE inhibitors and patients who are on statins, they actually have a lesser mortality and lesser morbidity than the patients who are not on. However, they studied about 9,000 patients, so they have a huge number. However, it was not a controlled study, so we cannot deduce a conclusion out of this, but it's a great observation that patients, and it further echoes our findings as cardiologists. We always say that keep the patient's medications the same as they were running. If these patients were on ACE inhibitors and statins, the chances are you have a stabilization of the plaque going there. That is a very important function. And you also have the ACE inhibition, which is essentially an LV cardioprotection that the ACE inhibitors tend to offer. It also works very well in diabetic settings, as already been alluded at perhaps with the previous speaker, that even in the diabetics, you tend to prefer ACE inhibition in these patients as much as possible. The burning issues currently, which are now, and those challenges that are constantly being analyzed and looked at, and every day to day, and sometimes hour to hour, these guidelines are changing. And you must have seen Dr. Fauci literally pretty much every day from the task force coming onto the news and then giving out some. But I like to follow what's going on his grand rounds, and I like to follow how he's been actually conducting his task force, because that's the crux of scientific data that one can derive from, and actually leave the media away and leave the rest of the scenarios away, if I will. So this way we can concentrate more as scientists, as doctors and scientists, and we can deduce, because evidence-based medicine is the medicine you want to practice. We know that huge challenges are there, both for public health point of view, as well as from the scientific point of view. But this is one unique historic pandemic that has engulfed us, and we really need to worry about this in a very, very sensitive fashion, so that this way, look at it this way, in the 9 months, we have not talked about cardiology, we've not talked about nephrology, we've not talked about anything else. All we have talked about is really COVID. And the reason is also because it is a multi-system disease and engulfing pretty much all of us as specialists from all different faculties into one syndrome, one disease per se. And it is a very, very unique. To summarize quickly, I know we have a very limited time for all the speakers. We really want to open a lot of time for the questions and answers. I'm sure all of the rest of my panelists, they will all agree. But I'd like to say one thing, that, the COVID virus per se is not something which you can dismiss easily and will not be eradicated out of this planet that easily. It's not going to go away. A lot of people say, oh, by the way, there'll be a miracle and something will happen. No, it's not going to happen. You wish. I mean, miracles do happen, but you wish. But the key is that this is all, and we are all in this together. From Nagpur to New York and all the countries in between and all the cities in between, we have to understand that this is one family on this planet which is really working very, very hard to try and help the common people, try and help the common doctors and everybody else in between, so that this way we can all work together as a team to combat this disease. Otherwise, we'll be in this for a long, long haul. So I personally feel that this is something that we can all work together, and we can do more often of these and bring that message home to all our, not only to the general practitioners, but also to the nurses, to the paramedical staff. I do want to salute the doctors and the nurses who have been on the front lines in Nagpur, in India, and of course here in the United States. We are all there. Some of them have contracted the disease during the process. Unfortunately, some passed away. I have 2 colleagues who passed away. I have to say that. And so with a very heavy heart, my heart goes out to their families, the loved ones who are standing on the front lines to help in this pandemic. And it is something which is very, very beautiful for us, that we are here to help our patients, and we recognize each other, brothers and sisters, that we are helping in this situation. I thank you for the time, and over to you, Amol.
Yeah, thank you so much, sir, for excellent deliberation. As I told you, we'll be taking questions at the end. So coming to our next speaker, who will be speaking on COVID and chronic lung diseases. He is none other than our stalwart in the field of pulmonology from Nagpur, Dr. Ravindra Sarnaik sir. He's MBBS, MD, DNB Medicine, DM Pulmonology, and DNB in respiratory disease. He is the ex-professor and HOD of Respiratory Medicine, NKP Salve Institute of Medical Sciences, Nagpur. He's a member of WHO COPD India. He has many national and international publications. He's presently the chairman of West Zone of India Chest Society, and he's also president-elect of Academy of Medical Sciences. May I request Sarnaik sir to please go ahead with this presentation.
So good morning, everybody. First of all, let me apologize for there is some breakdown, but fortunately now it is working well. I thank IMA for having thought of me within a week's time on the similar topic of COVID. And as all the speakers have highlighted, COVID needs a lot of discussions. However, COVID also has a limitation in understanding as day by day passes. A lot of literature, a lot of new things that are oncoming. So in fact, the allotted 8 minutes for next 8 minutes or so, the time allotted is to discuss the respiratory comorbidities and COVID. If we look at the literature, it has been highlighted almost over 6 months now that most of the mortalities or whatever the morbidities that the COVID is bringing on to the patient is primarily focused at elderly population, and invariably they probably would be carrying some comorbidities along with. Few of the other comorbidities having been discussed, what is alarming is the respiratory comorbidities can complicate the COVID infection. And as we initially understood, COVID is a respiratory specific kind of infection. However, it can cause extra pulmonary manifestations. When we look at the respiratory comorbidities, primarily many of our patients either have bronchial asthma or COPD or lung cancers, cystic fibrosis, not very common in our region, but in Europe and other countries. And they would be pre-existing so many other illnesses. The one to add and focus would be interstitial lung diseases. Again, for interstitial lung diseases, there would be so many differentials, almost comprehensively etiology can be 150 plus disorders, but even drug-induced lung diseases will add to that. So just to summarize briefly the various pre-existing respiratory issues which actually get complicated once there is a COVID infection. There has been few literature available now over the last 6 months, and the primary focus would be again going back to somewhere in January, February, where initial morbidity and mortality was reported to be very high from China. And of course, there are few other reports which we can review and update ourselves. But fortunately, for managing bronchial asthma, if the patient is taking regular treatment for control of his symptoms, it is mandatory for him to continue the same set of drugs, medication, inhalers, including inhaled corticosteroids to keep his symptoms stable. Because when we talk of comorbidities respiratory, majority of them are likely to cause either cough or breathlessness. And unfortunately, they are almost the same symptoms for COVID. So many patients' anxieties can be well controlled, and it has been seen that over the last couple of months, the compliance and adherence to bronchial asthma therapy by asthma patients have gone up by 14 to 15%. That is primarily the adherence is maybe the patients are little apprehensive not to get these symptoms. At the same time, there are few studies where the steroid has been, or the inhaled steroid specifically, has been shown to prevent the exacerbation of asthma, at the same time maybe to some extent severity of COVID infection. So there are a few myths and facts. I will not read out all of them, but do not stop asthma medicine or controller, and be prepared to treat exacerbations of bronchial asthma with the same medication, especially if the patient is taking higher inhaled steroids, can continue with the same dose because his symptoms or the acquisition of COVID infection has not been reported to reduce. Coming to the COPD, there are now, we will focus at this one of the initial studies. What has been shown is over 1,000 patients from Wuhan, hypertension, diabetes, comorbidities, as you can see, around 2% patient had COPD. And amongst the subsequent trials, on the right-hand side, you can see the lots of records and the studies reviewed has shown that around 2 to 18% of the COVID sick patients, those who are coming to the ICUs, are likely to have comorbidity in the form of COPD. Again, coming back to the management, the patients of COPD need to have stabilization of their primary problem with the currently recommended baseline treatment that they are taking. One thing that I would like to highlight here would be a severe COPD patient. The severe COPD patient primarily has compromised lung functions. Some of them may have respiratory insufficiencies, and few of them might have developed either pulmonary hypertension or hypoxic inefficiency or hypoxia during night. So they are on supplemental oxygen. So in fact, those are the patients, if in case by any chance they develop COVID, we primarily focus at hypoxia or so-called happy hypoxia. These patients, hypoxia and COPD severity are little difficult to understand at a community level or at a family level. So these are the subset of patients where clinician needs to educate individually, tailor-make the symptom score for that patient. Especially some of these elderly patients may not have fever when they are infected with COVID. As we now see, the number of cases having fatigability, body ache, other non-respiratory symptoms have gone up or have been reported little higher in these patients. Just to summarize, in COPD has been reported in ample number of studies now. And of course, there would be other comorbid conditions like either lung cancers, and I will not go into details of them because commonly prevalent are the COPD and these illnesses. What is most important, coming back to the respiratory affection by COVID, is to understand COVID that it is not behaving like an typical ARDS. Might be the best treated, like whatever suitable treatment. I will just try to narrate the respiratory physiology because pre-existing compromise of the lung function of an individual, low driving pressures are seen amongst the ventilated patients. Thus, it appears that the compliance of the lung is fairly normal, unlike most of the traditional ARDS. Silent hypoxia again needs to be highlighted here that a normal lung compliance may cause the patients to have relatively low work of breathing. And prior to intubation, many of these patients may not really have the kind of respiratory distress that is many times noted with the other ARDS patients. And these are the patients where the clinical guidance at the same time, maybe arterial blood gas and other supportive investigations will decide about the early intubation of these patients as compared to the other hypoxic patients in non-COVID patients. And then highly recruitable lungs are the patients who normally have ARDS. They require high PEEP. I will come to that in a few of the next slides just to understand how these patients' hypoxia needs to be corrected. By and large, the favorable response to pronation is another area which we should understand that along with the typical CT scan finding of peripheral basal consolidation, this might be consistent with the significant contribution by basilar atelectasis. So surrounding the affecting lung, interstitium or the maybe alveoli at the basis, they would be in addition to the shadows casted on CT scan, there might be a micro atelectasis at a basilar level, which is not picked up by any other investigation. In addition to that, this patient also tend to have coagulopathy. So intravascular or micro circulation of lung parenchyma, if affected because of thrombosis, again may not be picked up on X-ray chest. So this causes ventilation perfusion mismatch. Patient may not sense this hypoxia because his lungs are complying well. There are no stiff lungs at an early stage. This is a peculiar feature of almost 50% of the patient. So coming directly to now the pneumonia of COVID, which complicates the pre-existing morbid condition, one should understand the distinct features that almost 50% of the patients severely hypoxemic because of COVID may not present with primarily with breathlessness as their symptom. That is why we are advising them to monitor the pulse oximeter at home. The normally breathing patient or silent hypoxia are remarkably dyspneic also. So some patients who have silent hypoxia would sometimes be complaining of exertional breathlessness. That is why we advise them to do a 6-minute walk test. Severity of these infections primarily is decided by the host response, physiological reserve, and comorbidities. So this is what is our today's topic of discussion: pre-existing comorbidities. The patient's symptom score would be relatively higher as against primarily only COVID patients. The ventilatory responses of these patients are dependent upon the severity of hypoxia and relative severity deterioration. If patient abruptly deteriorates, if there is hypoxia coming up in few hours, then that is the patient who will immediately start complaining of breathlessness. The time elapsed between the disease and observation at the hospital would be another indication that patient may get acclimatized to his hypoxia and may not be complaining of as much breathlessness as what the blood gases are showing. So if we now come back to the lung parenchyma, there are two types of phenotypes of the lung parenchyma, L type and the H type. I will not go into the details, but this is very important to understand. The comorbid conditions would reduce the lung elastance, will increase the lung resistance, and they would be more symptomatic, difficult to manage patient. As against isolated COVID, L-type patients would have low elastance, highly compliant patient. They will require minimal ventilation, but they will also likely to have the light lung, like they're not much filled with the fluid that we normally see with classical ARDS patient. As against the H characteristics, high elastance of these patients would basically cause right to left shunt at a higher significant level, and the lung also is little weight because it is containing more fluid, and it requires little high efforts to recruit these atelectatic segments of the lung. So COVID pneumonia, these are repetition of pathophysiology of a morbidity if the patient already has old pulmonary tuberculosis, bronchiectasis, or cystic fibrosis, or like with so many other respiratory conditions like interstitial lung disease, or idiopathic interstitial fibrosis is also not very uncommon these days. These patients would have limitation of their ventilation, and this is how the lung physiology of either low volume or patients with high density of the interstitial edema patients, low lung recruitability. These are the technical issues, the challenging issues to ventilate these patients. These again can be skipped because we have limited time. We will have more question answers regarding the morbid conditions in the background. But how does all this understanding help us managing these patients? This is just a pneumonia patient. When the patient has L-type, that the CT scan on the left top is an L-type of phenotype of these patients. They can be managed by minimum oxygen supplementation. If they require, they can have little high flow oxygen, they can have HFNO, and most of these patients are managed with the top bars that we are seeing here. Few of them who deteriorate, they have a stiff lung, the one that is imaged on the left lower down corner, and they would require higher pressure, they would have more resistance, and non-compliant lungs requires difficult times. This is again just to have at a micro level. As you can see on the left side, the normal elastic lung, and on the right side, that is how the atelectasis in the surrounding affected area is. So the H type is little difficult and tough to manage. H type, you have a more refractory hypoxia as against the L type on the left side, which can be supplemented with minimal oxygen, and most of these patients will maintain saturation at a physiologically more than 94. Then, of course, non-invasive ventilator has taught us in COVID a very important thing, that this is just a comparison of a bi-level or a BiPAP with a CPAP. As you can see, the red here, the blue bar here, the CPAP per se will increase the peak airway pressures, and most of these patients can be very easily maintained, especially corrected for their hypoxia by simply giving only CPAP. There may not be much advantage of using a bi-level or a BiPAP for these patients, because CPAP per se will actually increase the mean airway pressures and oxygenate these patients much better as against the invasive ventilator. However, the one that I have shown, the stiff lungs would require mechanical ventilation. They would require routine management, like what is normally approach of ARDS, principles of ARDS with low tidal volume. We will not go into detail that. Another comorbid condition, which many times is overlooked, but extremely important, what I have seen in last 6 months, is anybody who is diagnosed COVID, freshly diagnosed, and obese. This is a very, very poor combination in terms of prognosis. Many of these patients have a low tidal volume. To start with the infection, they already will have minimal amount of basal atelectasis due to impact of COVID, can cause more hypoxia for these patients. These are the patients where simple supplementation of oxygen may not get as much well corrected because they are breathing at a low tidal volume. And of course, to add to this, obesity per se will have metabolic syndrome, hypercoagulability. So oncoming deterioration of these patients are little tough to manage. It will be always safer to keep them as a comorbidity with high suspicion for hypoventilation. I think I will like to end here. We will have more question answers to discuss further. Back to Amol.
Thank you so much, sir. As the webinar was progressing, I was flooded with many questions. I'll be starting this question answer session. My first question is to Dr. Pankaj. So the question to you is the management of hypertension different in acute phase of COVID?
As I said earlier, there is no difference in management of hypertension during acute phase of COVID. We need to continue our ongoing antihypertensive treatment during COVID. Only exception is diuretics here. The diuretics need to be reduced because already these patients are, because of fever and because of less intake, these patients are volume contracted. So there is no use of diuretic in this patient. You can reduce the diuretic therapy and see how hypertension is. Otherwise, rest of the hypertension treatment can continue. There was controversy about the ACE and ARB, but we know that these treatment need to be continued. There is no evidence that it harms the patient. And other thing is that short-acting beta blockers are important in this patient because they will have autonomic dysfunction, they will have tachycardia. So yes, short-acting beta blocker need to be continued. Most important thing is don't keep their hypertension untreated. Untreated hypertension will have adverse outcome in long run. And that's why they need to be adequately controlled with whatever antihypertensive regimen, their blood pressure get controlled.
Yeah, like Pankaj sir, you have said, you have touched upon the ACE and ARB controversy. I want you to little bit elaborate on this. What was this controversy about, and what is the final word on ACE and ARBs?
Yes, can I share my screen?
Yes, please.
I think it is visible.
Yes.
So basically, RAS system is a treatment RAS system, which is one of the modality by which we treat hypertension. So ACE inhibitors and ARBs, basically because of inhibition of ACE, there is an increased level of ACE2. And this ACE2 is one of the important entry point for COVID virus. It is present on the endothelium, it is present on the epithelium of lung alveoli, as well as on the myocardium. So once we inhibit this ACE by ACE inhibitors or by ARBs, there is a upregulation of ACE2 levels on this myocardium as well as on the epithelium. And that's why there was a controversy. There was a thinking that if ACE2 levels increases, there will be increased chances of infectivity in these patients with hypertension. So those patients who are taking ACE inhibitor, there is an increased chance of infection with COVID virus. Secondly, there was thinking that since these are present more on the cell surface area, there is chances that these cells will get destructed by the COVID virus. But none of this biological plausibility has actually seen in case of real scenario. The study after study has shown that though the ACE2 levels are more in these patients with ACE and ARB treatment, but it has not resulted in any increase infectivity, as well as not resulted in any of the increase in morbidity or mortality in the patient who ultimately contracted this COVID infection. So definitely there is no no justification for discontinuation of ACE and ARB, because there is a compelling evidence that the patients with LV dysfunction, patients with heart failure, patients with diabetes mellitus will benefit more by continuing ACE and ARB.
Yeah. Okay.
Let's follow up on that just for a
Yes,
second.
Dr. Jetli, you want to add something?
Yeah, I just wanted to follow quickly on that and what Pankaj has already said, but I think I said that in my talk earlier also, that the study from New England Journal of Medicine only in April of 2020, somebody can look it up if that's interesting to them, and Mera, and he's talking about, he's reviewed 9,000 patients, as I said earlier in my talk, and all these 9,000 patients, they were on statins and ACE inhibition. Having said that, these patients actually had lower mortality, which is good, which is lower mortality in the COVID setting. So there is something happening here. However, this is not a controlled trial. It was just a total observational, just a clinical observation in those 9,000 patients. They just screened them. They saw 9,000 patients in Boston hospitals, and people who were on ACE inhibition and statins, and they found. So sometimes, the take-home message out of this, as I always say, is the best antiviral drug may not be the antiviral drug. You follow what I'm saying? So it's not the antiviral drug. It may be the ACE inhibitors and statins. We don't know. That may be the guidelines that might come down the line, because it seems like it's a vasculopathy. This COVID is going to be affecting the endothelial system as it's already doing it. So it may be a vasculopathy. In fact, there is an article which is already in the Journal of Cell, and they are talking about renaming this virus. Already we have 19 names perhaps, but this is going to be called as vasculotropic virus, if you will. I just want you to know that it is a vascular condition, it's an endothelial condition, and we are addressing that.
Yeah. Dr. Ambulkar sir, can you hear me? Yeah, can you please start your microphone? Yeah. Ambulkar sir, I have a question for you. Why sugar control is important in acute phase of COVID infection? What is the physiological basis of it?
You see, normal blood sugar needs to be maintained. If the blood sugar goes more than 180, 200, then there are problems with the macrophage and the leukocyte functions. They do not function properly, and there are high chances of getting all kinds of infections, and also the comorbid states. So it's always better to control blood sugars. As I said, the fasting needs to be 100 to 120, maybe up to 140, and post meal need to be 140, 160. The initial thinking was like fasting should be between 80 to 120 and post meal between 100 to 140. With this, the chances of hypoglycemia were much more high, and morbidity associated with hypoglycemia was high. So better figure would be fasting 100 to 140 and post meal 120 to 160. That should be maintained.
Yeah. Another thing is, you have already told in your presentations which medications to be avoided. I want you to little bit elaborate on why metformin should be used with caution, and what is the rationale behind stopping thiazolinidones and dapagliflozin or SGLT2 inhibitors.
So, this patient usually have nausea and vomiting, and they have a tendency towards if you use the metformin in such situations, then there is the chances of getting more of a lactic acidosis. So in any acute infection of whatever kind, one should withhold metformin for a period of infections. As far as glitazones are concerned, they are known to have fluid retention. And in a patient of this patient with cardiac compromise, the fluid retention will be more and the cardiac morbidity will be more. As far as the SGLT2 inhibitors are concerned, they tend to cause hypotension. They are excreting glucose in the urine, and they have a tendency to cause euglycemic decay in the presence of infection. So maybe by some inhibition of insulin, especially insulin-dependent patients. So SGLT2 inhibitors, glitazones, and metformin should not be used when the patient has got active infection. On the recovery, then they might be restarted again.
Yeah. On this note, Dr. Jetli, you being a cardiologist, I know many cardiologists are also using SGLT2 inhibitors left, right? So what is your take on SGLT2 inhibitors in cardiac patients in COVID era?
One, it has been obviously cardioprotective. And two, you should be not changing in the midstream any of these medications. The patients are already on it, as Dr. Sunil is talking about. So I think it's very important that we maintain, as long as it's all, the patient is in euglycemic state, it's a cardioprotection, essentially, that you're also, offering to that patient. So there are no clinical studies that people have taken them off or but at least not that I'm aware of. But the fact is that if somebody's already, because these, even prior to the pre-COVID, remember, pre-COVID data already shows that if drug A performs better in heart patients, why take those patients off? And that's your take-home message out of this. So you want to keep them on.
Okay. Yeah. Sorry.
I was just asking, does that make sense, Sunil?
Yes, yes. Excellent.
Okay.
So
Yes.
I think SGLT2 drugs will be more used by cardiologists than endocrinologists henceforth.
Yes.
I think so. This is one of the guidelines, and I think the cardiologists are going to steal away this drug as well into our armament. Sorry about that.
Yeah.
Yeah.
Yes.
Sanaik sir, coming to you, what preventive strategies you would like to propose in the patients with chronic lung diseases?
Is that for review?
Preventive strategies, in fact, itself is a primary focus for the patients who actually have a pre-existing illness. All of us are well aware about the preventive strategies in the patients with chronic lung disease. There would be primary prevention, secondary prevention, and tertiary prevention. Primary would be, of course, the patient education. They will need to have proper healthy nutritional habits, diet, regular exercise. Then they will have to avoid tobacco. Very important that they should also avoid airway irritation due to particulate dust matter, maybe allergens around change of weather, exposure to extremes of weather. So these are the primary prevention. Secondary and tertiary preventions would be, as and when patient has exacerbation, will be secondary. Then whenever they have a risk of further deterioration, then they will have to individually tailor-make the advice for that patient to avoid similar issues. Of course, if the patient has been having chronic respiratory diseases, they would be advised even the immunization or vaccination for other infections on a regular basis. And of course, if by any chance patient unfortunately gets COVID, would be tertiary advice that post-COVID, again, they will require special counseling. They also will require pulmonary rehabilitation. That's a very important thing that is making its headway even in now developing countries, because these are the patients who will already have compromised lung, and subsequent to that they are having risk of further lung fibrosis, as has been noticed in last couple of months now. So one has to educate these patients. They have to take proper nutrition, and rehabilitation is nothing but these patients will be enrolled for some program or protocol wherein they would be having respiratory physiotherapy. It is not simple in and taking deep breath and exhaling out, but there would be a lot of conditioned exercises so that they will have good endurance of their respiratory muscle, competence to actually have a better coping up with their hypoxia. Of course, they will also be requiring a lot of supportive counseling, and because these patients are likely to have a lot of depression, fatigability, so that also needs to be addressed for this tertiary prevention program.
Yeah. Sir, another thing, a couple of months back, there was a viral video on social media and everywhere about a Western doctor claiming that budesonide is pump of budesonide or nebulization of budesonide is a miracle therapy for all COVID patients. Sir, what is your take on it?
In fact, that's a good thing to ask about, because social media is playing a very critical role in lives of many social community as of now. This is just to highlight that what the video you were talking about. In fact, it was projected as a silver bullet to control COVID, and it went really viral. And in fact, if you really look back and review all the literature, what has been now confirmed that as of now, the further research, especially for cyclocyanide, is ongoing more from Japan, whether it can reduce the severity or cause significant reduction in the symptom score of the patients of COVID. But as of now, budesonide is a treatment to be used for bronchial asthma and not a cure for COVID. So there is no study as yet which has proven that it can really benefit these patients at this stage.
Yeah.
Can I have one comment, please, Amol?
Yes, sir.
I want to have your opinion of the house. This is a virus infection where the cell-mediated immunity is most important for protection. How is the place of plasma therapy in this viral infection? Is it overrated, underrated, normally rated? It's very important to know, does the plasma therapy make any difference?
Dr. Sarnaik, you can answer this question maybe.
In fact, this is the lots of studies ongoing. In fact, there has been 1 or 2 arms of these long-term studies already withdrawn. And this is a very significant question to be answered more through research than on the forum like ours. But then plasma has been used in critical patients. There are 3 things very important when you are focusing this for COVID. Number 1, we have to understand the COVID severity score. The mild to moderate, see, primarily plasma for these patients of COVID has to be used as a primarily antiviral agent. So when there is a little high viral load, patients have mild to moderate illness. The moderate illness where the other recommended therapies are not very effective, that is the right and ideal time at an early stage to use plasma for these patients. It has to be again tailor-made by the individual physician regarding the indication, and proper window of opportunity has to be tapped so that the viral load can be restricted by through use of plasma. However, the social messaging, many times you get an impression that it has come out as a very important, significant kind of therapeutic modality. But one should understand the research will only guide us further. As of now, it has to be judiciously used only in moderate cases, not after 8 or 10 days or not after 8-10 days of ventilation. That may not be the right time to use these kind of medication.
Yeah. There is a specific question coming from public for Dr. Jetli. We all have seen Mr. Trump in his speech talking about HCQ and all. The people want to know the role of HCQ in treatment of COVID in cardiovascular patients, and what is your experience with HCQ?
I think the question should be addressed to him directly. But in any case, I think we have the answers already, because if you look at it scientifically, and if you look at, I mean, there have been 250 trials globally on HCQ, and none of them really panned out to show that there was any benefit on prophylaxis or treatment. So I think we can throw it away for now, because we have other things right now on the burners. But having said that, I just want to follow up on what Sunil was talking about with the convalescent plasma therapy, because that's where the thinking is going, but not that it is the answer for therapy. We don't have therapy for COVID, truly speaking. But FDA approved it only on an emergency use authorization, EUA as they call it, on August 23rd. And which implies that only certain physicians will be able to do the plasma, will be able to offer the CCP, which is the COVID convalescent plasma therapy. It has to be done early in the course, like you said, and it's very important that window has to be assessed clinically. It just cannot be given, across the board to everyone. And what remains to be seen is, are there high titers which are really neutralizing the virus, the inoculum dose? Will that impact on the therapy? That needs to be still seen. So we don't know yet how it's going to really pan out. It may be one of the best ways really right now to prevent patients going into the ICU and becoming more sick, and next thing they're on ventilators. It could be one of the areas where we could actually make a huge dent in the mortality. This is where I foresee it. But that's just a vision of mine and from my reads and from my understanding. But I'm not too sure whether that will become the therapy still. But and also remember collecting these convalescent plasmas. I don't want patients to go running and say, by the way, we go to the blood banks and start donating. You know, you could do that, but the fact is that I don't think, and likewise, doctors just can't start ordering. There are certain blood banks only, even in the United States, which are now designated to take the plasma of the convalescent patients, because it has to be done very, very carefully, because you're dealing with obviously in sterile conditions, but you're also dealing with COVID in those blood banks, so you don't want to have any of those problems either. Thank you.
Yeah, my next question goes to Dr. Pankaj. Dr. Pankaj, as you know, there's a big chunk of patients who are being treated at home in their home isolations. And these majority of these patients do have a lot of comorbidities. I would like to have your opinion on how you should monitor cardiac patients at home. Yes, Dr. Pankaj, can you hear me?
Yes, yes, yes.
Yes, please.
Can you share the screen?
Yeah, you can share the screen, please. You can share.
So basically, home isolation and cardiac comorbidity is an important issue, because these are the patients which we want to monitor closely. So if still they are home isolated, if the patients are stable, we need to monitor their heart rate. We need to emphasize that just monitoring pulse oximeter, we have to monitor other parameter which is shown on the pulse oximeter is heart rate. Tell your patients that heart rate is important parameter, and tachycardia shown in otherwise asymptomatic patient is important parameter, that this patient may deteriorate and these are the high risk patient. Get these patients cardiac enzymes baseline if possible, the troponin and BNP and ECG, of course. These are the three things, baseline parameters, which we want to do in this patient. These patients need to be in touch with their treating cardiologist, because treating cardiologist knows their heart's condition, their previous reports, their exact reports on previous angioplasty, bypass surgery. Though they are home isolated, they need to be in touch with their treating cardiologist. They need to keep their records ready for future if admission is required, and keep low threshold for admission if the symptom worsens. So these patients need to be prioritized for their admission if the symptoms worsen, not the other patient with just only no comorbidity and just fever, high-grade fever, and just for anxiety. If patients in a scarce bed scenario, what we need to ensure that these red flag patients need to be admitted on priority basis, rather than the other patient who are just who are not having any comorbidity. So we need to ensure some bed for these patients if these patients are home isolated.
In addition to this, Pankaj sir, what about adding a oral anticoagulant to the home isolated patient? Actually, is there any role, and which anticoagulant should be preferred?
So here oral anticoagulation, routine oral anticoagulation in home isolation patient, there is no necessity. But if certain cardiac enzymes like D-dimer has been done and there is a 3 times elevation of D-dimer, then definitely this patient needs anticoagulation. But I will suggest that if these patients D-dimer is elevated, they need to be in hospital, not on home isolation. So patient with comorbidity, raise D-dimer, definitely they need to be in hospital. And anyway, state task force guidelines says that the patients who are hospitalized need to be on anticoagulation, and they need to be. As far as role of antiplatelet is concerned, yes, there is a role of antiplatelet in this patient. Patient with cardiac comorbidity, we can think of starting low dose aspirin. because already these are the patients who are prothrombotic milieu, and on top of that, these patients has developed COVID, which is again, we know that there are chances of further aggravating the prothrombotic state. That's why there is a role of antiplatelet therapy in these patients. So prophylactic anti-therapy in patients who has got comorbidity is important. Without comorbidity, asymptomatic patient, there is no role of aspirin. But with comorbidity, definitely we can think of starting antiplatelet if there is a bleeding risk is not high.
So can we use that rivaroxaban at home, or can we advise that? Few people, I have seen a few prescription that they are advocating Xarelto, 10 milligram
Yes.
daily.
So basically, Xarelto is a rivaroxaban. It is a oral anticoagulant, novel oral anticoagulant to say. So monitoring will not be required. But the subset of patient which require this oral anticoagulation is very small. The patient, if patient has got cardiac comorbidity and cardiac this D-dimer is normal, there is no role of novel oral anticoagulant. But yes, the patient who has got COVID and who has been treated with injectable anticoagulation during his hospitalization, these patients on discharge may be continued on oral anticoagulation like rivaroxaban for at least 28 days, and post 28 days, these patients can be shifted to oral antiplatelet depending on their bleeding status.
So, thank you, Dr. Pankaj, for those take-home messages. It is very clear. You have said that if the D-dimer is more than 3 times the normal, you are justified to use these drugs. There were questions about on the same line from the public by Dr. Dr. Mrunmayee. What she wants to know is there a role of blood thinners in asymptomatic COVID positive patients? Blood thinners, maybe she's trying to say about antiplatelets in asymptomatic.
Yes, so blood thinner can be 2 groups, antithrombotic, antiplatelet. So antithrombotic, as I have said, hospitalized patient, non-hospitalized patient, only if D-dimer more than 3 times of the normal value, then only you are justifying in giving antithrombotic drugs. As far as antiplatelets are concerned, definitely you should consider in patient who is having cardiac comorbidity. Definitely you can consider starting antiplatelet as a prophylactic.
Yeah. So on coming to the similar lines of home isolation and home isolation therapy of the patients, my question goes to Dr. Ambulkar sir. Sir, can you give some tips about managing sugars at home in the home isolation patients?
Yes, the patient has got a mild diabetes and the oral intake is adequate and he's mobile in the house. He can do the blood sugar monitoring on the glucometer and can continue with his treatment either with a form of insulin therapy and works with it and or oral anti-diabetic drugs. Not that every patient needs to be hospitalized. There are only certain indications of insulin therapy in the hospital. Otherwise, mild patients, asymptomatic patients, can follow their daily routine. They might have some changes in their medications, like I said, metformin and other drugs needs to be cut down, and they need to monitor their diet, exercise, watch for hypoglycemia, and take the treatment accordingly.
Yeah, sir, I have a question for Dr. Sarnaik now. There are many patients who have been prescribed N-acetylcysteine. Sir, can you elaborate on its role, N-acetylcysteine's role in COVID, and should it be used in all patients of pneumonia?
As one know now, I think there is a lot of apprehension regarding the long-term sequelae, and of course, whatever the acute lung injury the coronavirus is causing to the lung. There are lots of drugs, there are lots of clinical trials ongoing, so NAC would be one of them. If you look at one of these recommendations or one of the papers that recommended is actually, it's a cocktail or a combination of N-acetylcysteine, copper, colchicine, and nitric oxide in combination, and they are supposed to act at multiple levels in the various cytokine-related inflammatory cycle. So as of now, there is nothing like any magic drug or any individual drug that is going to control the cytokine storm or the ongoing lung inflammation or whatever the patient's ongoing coagulopathy. So NSE primarily was more intended to, as you can see on the left-hand side, if the patient has vitamin D deficiencies, calcium levels are low, these patients are likely to tend to go in the cytokine storm. So that is where the action of NSE was projected. There are few studies, but there is nothing very authentic. However, we will get to know this about the NSE because there are 3 trials ongoing. So we'll have to wait. But as of now, there is no such recommendation to use this drug.
Sarnaik sir,
Yeah.
I just want to ask you, there is a hype about ivermectin, and is this a rational drug to use in this COVID patient?
See, primarily now there are all the drugs, whatever available, are pre-existing molecules which are available, FDA approved for use for some other alternative illnesses. As you understand that whatever new drug through research to be effective in a given illness requires a lot of research, RD, time consuming, and corona needs some kind of therapeutic interventions. And that is the reason there are lots of drugs now which have been considered by various guidelines, and these are basically repurposed drugs. So there would be few anecdotal kind of publications or the material available through which some of the guidelines have been taken these kind of drugs. So coming to the specific drug, if you look within our country itself, if you look at the ICMR guidelines, the ICMR central guidelines have been modified, although it's a central government recommended guideline. Every individual state will try to have their own guidelines, like our Indian Maharashtra state also have the state task force who have our own guidelines now. So having seen that, if you see ivermectin is one of the recommendations, the initial stages of illness in Uttar Pradesh. But as of now, the Maharashtra state guidelines doesn't mention about it unless the patient has some the side effects of the initial antiviral drugs. Has been mentioned as a second line drug, but primarily as a preventer. Many of these patients, they have already consumed it while looking at the either Google search or maybe looking at the guidelines which actually are not to be used in our region. But as you understand that every forum is open, the repurposed drugs are already available in the market. Because the drug is not recommended by our state government and task force, it has to be individually decided by the clinician, especially for using the drugs which are not mentioned in the guidelines.
Yeah. Sarnaik sir, thank you for that note. Here I would like to add Dr. Jetli. Dr. Jetli, are you people using ivermectin, doxy, and these drugs in US?
Not that I'm aware of, but there are anecdotal reports where they're, obviously they have shown some benefits, but no, not across the board. It's so important that we try to streamline the therapy in a clear scientific way. Like if you were to use an antiviral drug, like, as you know, remdesivir has been approved now, again, under very closed authorization, again, by certain physicians only who could actually handle that drug. Normally given at 200 milligrams IV the first day and then followed later by 100 milligrams for the next 9 days. What it has shown is definitely it has shortened the recovery time because these patients who are on mechanical ventilators, patients who are on CPAP or who have trouble getting weaned off from in the intensive care unit, those are the sick patients where this antiviral drug has shown to actually, and it's a double-blinded placebo-controlled trial. It is a fully ethical scientific trial. So I tend to believe more in scientific trials, evidence-based medicine, rather than anecdotal reports like you were mentioning about as one of the audience people were asking about. So it's very, very important that we easily get carried away we like this because we're so desperate right now. Let's put it this way: we are so desperate. Even if somebody gives me carrots and says, "By the way, it's going to go away," I'm going to take it if I tend to believe it. But the fact is that I know it's not going to do any harm. But the fact is that is it going to be beneficial to me during this pandemic? That's the key, and I think we need to ascertain those things. What is really in the pipeline right now are the vaccines, because the race is, I don't know whether you're going to touch upon that briefly or not, but I just want to say in 60 seconds, the vaccines are going to be a game changer here the way it seems like, because that's the only way one can actually immediately control those asymptomatic people who are walking around, because that's a 50% of the entire pandemic group, if you will. They are healthy. They've seemed healthy, but they're all up and down the elevators. They're all up and down in the markets. They're all having fun. Every Friday they're out in the parties. So it's very, very important. And some of them, perhaps they're not following the guidelines, which is so important. And we still have to. And, you know, Dr. Fauci is still coming back and saying the same thing over and over again. It seems like he's speaking like a broken record. And that is unfortunately because people are not following the guidelines. Why do you think there are newer hotspots in India? Why do you think there are newer hotspots in certain states in the United States? Why do you think Spain is again starting to show a surge? Why do you think Spain and Italy, they are again starting to show these surges, even though they were very, very, very helpful in suppressing it? New Zealand, on the contrary, has not reported a single case, by the way, in the last 90 days, I think last I checked, which is amazing because they totally shut down the country. It's a small country, obviously, but the fact is that they totally shut down the country, and they very cautiously, every single one of them, they made it mandatory to wear the mask. And, you know, so it's so nothing like still, I mean, vaccines are not here tomorrow, but the fact is that they are coming. But in the meanwhile, it doesn't mean that we can stop wearing and following the guidelines. Again, the point is I'm making is very important for the general public who are in the audience right now, who are following us, and people who are going back into their clinics and they're going to advocate to their patients in the real field, because that's where the emphasis is right now through all these webinars. Of course, we are discussing a lot of intricacies in scientific literature. Look at where we were in January. We did not even know what kind of a virus this is. And look where we are in November. And we still have only a 0.01% of the information out of this COVID. A point that very analogous to HIV, for instance, was, remember, and again, I'm referring back to Dr. Fauci, he quoted that they said that it's going to go away even in, when the HIV started in 1981. I had the pleasure of listening to him in various symposiums live and meeting him also during several infectious disease conferences when they were happening pre-COVID era. And interestingly enough, he led the task force of HIV in 1980s and 90s. And obviously, even today, we don't have an HIV vaccine. Look at where we are. And we have 78 million people, out of which 30 million of HIV have passed. So here, we are looking at 30 million cases in 9 months across the planet. 900,000 deaths across the planet, almost approaching 1 million. And of which, unfortunately, US has the worst so far right now. It's 190,000 here within this continent. And US, India, Brazil, and Russia, they are on the top in that order right now, where the number of cases, the number of deaths are occurring. So we have several hotspots on this planet right now, which need to be addressed as well. So it's not just one focus, but that's where the pandemic, that's why it's a pandemic, because people will fly back and forth. Eventually the economy will open. Eventually people will start to go back to their routine, which they are doing. But we cannot underestimate the fact that right now, this virus is a very, very serious issue.
Yeah. Coming to the cardiac diseases, Dr. Pankaj, do you think ISD and CAD patients have a different presentation in COVID era?
Yes, they will have different presentation. Basically, here we have to see that both types of type 2 MI as well as type 1 MI are presenting. Type 1 MI is where there is a thrombus, there is a atherosclerotic plaque which get ruptured and superimposed thrombus. That is a classical MI which we see routine. But on top of that, what we are seeing during COVID period is that type 2 MI, where there is, because of cytokine storm, there is elevation of troponin. There is no underlying coronary artery disease, still patients showing ST elevation MI, raised troponin. So it is basically because of the supply mismatch and because of the cytokine storm. Type 1 MI, which because of the prothrombotic state are increased, but presentation is very late because people are very afraid of presenting to hospital, coming to hospital. So late presentation is very common. And the thrombotic burden, which we used to see in acute MI cases, is very high. So even if we do thrombosuction, this thrombus is not going away. Sometimes we have to leave this patient without stent. We have to manage them conservatively on heparin therapy, and subsequently we have to deal with that thrombus. So thrombotic state in type 1 MI is more. Type 2 MI are seen increasingly common, that is MI without any underlying coronary artery disease.
Yeah. Another question which came from Dr. Umesh Shamtani, who is managing a COVID ICU. He has a question that he's getting many patients in shock who are not responding to inotropes. His question is, what is the role of levosimendan in such kind of patients?
Obviously, levosimendan will be used in patients with heart failure. There is no role of levosimendan in cardiogenic shock as such. If the patient's blood pressure is maintained, then only we can use levosimendan or dobutamine for that matter. So, relatively borderline patient with severe LV dysfunction with heart failure, this is a subset where we will like to use levosimendan or dobutamine. For frank shock, I don't think levosimendan will work. Yes. Here, if inotropes are not working, we have to see the underlying cardiac status. How is LV dysfunction? How bad is LV dysfunction? And here comes the role of support devices, LV support devices in the case of intra-aortic balloon pump. And if available, ECMO will be the therapy for these kinds of patient, and that will only save these kinds of patient. No other treatment will work if a patient has got refractory shock and you have ruled out other treatable cause like volume contraction and other things.
Yeah. Coming to his own question, another question, I would like to put this question to Dr. Abulkar. Dr. Umesh again asks, because he's an anesthetist, he asks, what should be the pre-op sugars in COVID patients when they take these patients for elective surgery? Sir, your voice is not clear, sir. Start your this thing, mic.
Yes, yeah. That is a relevant question. You see, in emergency situations, higher blood sugars are acceptable, maybe up to 200 in emergency. But if it's not emergency, you have to prepare the patient for surgery. It's better to have fasting blood sugar around 120 and post around 140 to 160. And I think that blood sugar will maintain an IV insulin and IV normal saline drip before, prior, and after, and monitoring the blood sugar is important.
Yeah, sir. Yeah, please go ahead, sir.
Fasting around 120 and post meal or throughout the day 160, your patient is absolutely safe.
Yeah, there was a question from the audience also about thyroid hypothyroidism in COVID. The question is, do we need to increase the dose of LT4 in the acute phase of COVID?
No, if the patient is eating normally and there is no vomiting, then the standard dose of thyroxine is 1.6 to 2 microgram per kg body weight. It has to be taken on the empty stomach and don't have to take any beverages or any snacks, because the thyroxine therapy will interfere in this therapy, diet therapy or beverages will interfere in thyroxine absorption to the tune of 40%. So L-troxine or thyroxine therapy has to be taken in the morning on empty stomach, and you really don't have to need to alter the therapy if patient does not have any nausea and vomiting and absorption is not a problem.
Yeah, sir, lot of questions, Sarnaik sir, are coming regarding lung fibrosis. I would like you to throw light on role of pirfenidone and steroids in management or prevention of lung fibrosis, sir.
That's a very pertinent question if we look at the follow-up of these patients. Any patient who actually requires hospitalization, many patients who require oxygen supplementation for longer time, and patients who are requiring high flow oxygen for longer time. These are the patients who actually have been showing a lot of initial infiltrates which are acutely oncoming interstitial injury. However, over a period of time, these interstitial shadows, they go into confluence, and then many of these patients, by the time they are discharged, why I'm trying to narrate this is that within those 10 to 15 days, there has been noticeable changes in the lung parenchyma morphologically. However, this has also been evaluated in the autopsies. And there is always a fear that we, as of now, do not understand much about what the actually virus is going to do to the lung parenchyma. But we understand two things very clearly, that there is an acute lung injury or ARDS-like presentation whenever the severity of illness is high. And we also now understand that morphologically, these acute lung inflammation as a sequelae will cause interstitial fibrosis. And because it leads on to compromised lung function and stiff lungs, they tend to have a restricted kind of lungs after the discharge. And there has been good number of patients who fail to maintain normal oxygen at the time of discharge with those shadows in the CT scan especially. And many of them are going back home with home oxygen supplementation. And quite a few of our patients as of now are on home oxygen post-discharge. So this is a very valid question. We have to consider that these patients should fall back to their normal. The patients who walks into the clinic or the hospital for his COVID goes back on stretcher with oxygen supplementation. That's the exact scenario that we are likely to need to address. So there has been now few drugs. Again, they are mostly repurposed. They are available to treat the interstitial fibrosis. As we know, the pirfenidone is one such drug, almost 8 to 9 years of clinical experience, and not only FDA approved, but then it has been strongly recommended. There has been a lot of clinical benefits to the other interstitial fibrosis cases, especially so for idiopathic interstitial fibrosis. The whatever existing ongoing process of fibrosis has been substantially blocked by this drug. The drug requires the little higher doses for the body weight, and if the patient tolerates it well, possibly this can restrict the potential mechanisms of the fibrogenic injury that lung is having. There are few other drugs also in the research, just put their name because these are yet to come in clinical practice, but severe SARS infection also. There are two schools of thought. One is that during acute lung injury itself, a few of the shadows which are actually interpreted as interstitial fibrosis on CT scan, the pirfenidone has been started by few clinicians. Again, as I said, we are coming to anecdotal, or there are now official FDA registered trials ongoing on pirfenidone and COVID fibrosis. But whatever limited the data available and published, it has been started little early by a few of the clinicians, because the one of the major limiting factor of pirfenidone, the one message we would like to share with all our doctor colleagues, is that the drug is effective, or efficacy of these drugs is built up by mounting up the number of dose that the patient is taking. So to start with, it has to be started with low dose, then it has to be built up to the maximally tolerated dose, maybe somewhere around 2 grams. So in fact, that is the drug, that is the dose that many patients may not really tolerate. So all this mechanism itself will take 4 to 6 weeks, and that is where the pirfenidone will have its maximum effect. Why I'm trying to discuss out this is that one dose, one drug, 7 days short-term therapy may not help at all. So it will be effective only after 4 weeks of initiation of therapy. So oncoming acute inflammation by any chance is really causing the fibrosis, which is it's a self-perpetuating inflammatory mechanism. Then if at all the pirfenidone has to be effective, it has to be started little early before the patient lands up with interstitial fibrosis. As we understand, pirfenidone restricts the ongoing progression of fibrosis. As of now, there is no drug which can liquefy the existing lung parenchymal fibrosis. So this is the limitation of the drug. This is a drug which can be started early as per this set of the suggestions of the few trials. However, the patients who have been diagnosed to have interstitial fibrosis post-discharge would be another indication to start pirfenidone at that stage. For this drug has to be continued again in the maximally tolerated recommended doses, and it has to be continued because the total data available is only for last 2 or 3 months now. The ongoing trials would definitely point towards or highlight about this, because the selection of the patient, the dosing of the drug, and exactly when the drug was started, these are variable in the existing trials. So it is extremely difficult to correlate and contrast the existing available literature. But by mechanism, pirfenidone is an anti-fibrotic drug, that is available. It is relatively safe and can be considered in treating interstitial fibrosis. Last point I will like to add here is that few of the trials have shown that it has some peculiar anti-inflammatory effect. So while ongoing fibrosis, it might effectively help in preventing the ongoing fibrosis at an early stage through its anti-inflammatory unknown mechanism. So I think time only would guide us regarding its exact role, but this is what is the current literature available.
So you have to highlight something about steroids in prevention or treatment of fibrosis.
Again, if we go to the steroids, see, these are the drugs which have now the recovery trial. It has been suggested to use it in the moderate cases, and most of these moderate cases are likely to have interstitial fibrosis. And like so, the radiological resolution normally takes time. A very important message here is there is always a radiological shadow or resolution can come up after 3 to 4 weeks. So the clinical benefit that the patient gets with the treatment at the time of discharge, the X-rays may fail to show the equivalent response. And many of these X-rays which look very scary on follow-up we have seen in last 3 months now, that with time, most of these radiological shadows will definitely resolve if the patient's lung functions are right and if the patients are properly educated for pulmonary rehabilitation. Out of fear, many of the clinicians right now are giving a lot of patients with high dose steroids or continuing steroids. Already we have been discussing the diabetes, the comorbidities, and the use of steroids in these patients has to be judiciously managed. So unless indicated in a given patient, unless the patient really has been documented to have more fibrosis, nodular opacities, and not the alveolar kind of or interstitial kind of fibrosis, which will be resolving with time if there is no existing fibrosis or the fibrotic stage, which actually has been initiated or begun in that particular individual. As of all of us understand that steroid will play a significant role in initial inflammation, whatever cascade, but later on, once the fibrosis exists, maybe steroids will not revert the existing fibrosis. So having understood this, a judicious use of steroids for these lung fibrosis patients, which is an ongoing process. If we actually look at the interstitial fibrosis, the American Thoracic Society as well as the International Forum now is not recommending steroids at high dose as it used to be recommended even in the interstitial fibrosis, which is idiopathic in nature. Because with time, with the availability of specific anti-fibrotic drugs, the balance of the efficacy of the drug as against the adversities has favored more with the anti-fibrotic drugs than the corticosteroids. So corticosteroids in ILD per se are indicated during acute exacerbation or acute exacerbation of pre-existing ILD, or the diseases etiologically are something like drug-induced interstitial fibrosis or extrinsic allergic alveolitis, sarcoidosis. Again, in sarcoidosis, we have to pre-select the set of patients. So steroid per se has to be judiciously used in all COVID patients, and rather than empirically adding to just to reduce the lung shadows, which may not add as much as per the current literature available.
So this brings me to another question. Many patients who have completed their isolation period or have been declared cured, they are having this query, should we do a repeat CT? Would you like to answer this query? And if at all it is required to do a repeat CT, when is the correct time to do a repeat CT?
Right.
I think this is what the things are. If we follow up these patients with time, if you are using antiviral and you are expecting resolution of the CT or the shadows in CT scan, like this is one of our first of the patients in the month of April. On the left, you can see the illness, the nodular shadows, which were actually initially more reticular. Subsequently, the left-sided shadows, both the CTs are showing two different cuts. Nodular opacity suggestive of interstitial fibrosis. So this was the time when pirfenidone and nintedanib was both started, because patients was very keen that all these nodular opacities or fibrosis should be instantly halted. And as we understand, nintedanib will have quick effect. It is a low dose, although it's a very expensive drug, but it is now available over last 3 years, and it has been helpful to those patients where pirfenidone has failed. So this particular patient agreed to actually spend, and we have started both. And on the right hand side, this is just last week's follow-up X-ray or CT scan of the same individual. So this is where the fibrosis can be treated. We don't have any claims. Actually, this is an individual case only. We don't have the study, but there are lots of patients enrolled for that our center also. But this is the background that one should know, that the anti-fibrotic drugs will definitely have. Now comes the role of CT scan. I have already highlighted in my previous slide that repeated CT scan or X-rays may not really assist much. In fact, if you look at the state task force recommendation, the CT scan as a diagnostic tool has not been recommended at all. With the ease of the availability of the CT scan and maybe like the high sensitivity of the CT scan, few of the early casted shadows will be picked up. So they would be having the reports, whatever numerical value over 25, the classification I will not know, I will not go into detail. But what is important is those shadows, once they are noted or documented, unless there is a clinical deterioration of the patient, unless there is a comorbidity or indication of doing a CT scan, a patient who actually has risk stratification is very important to do an imaging for this patient. Assessment of the cardiopulmonary abnormalities can be picked up with CT scan because that may be clinically not perceivable at an early stage. A COVID negative testing in a resource limited place, maybe that can be indicated to a CT scan. And of course, the follow-up of these repeated CT scan may not be indicated because what has happened is the various shadows on the right-hand side. I am just trying to answer this question with the tabular form that from the CT language or the findings perspective, there are lots of variable shadows which are casted in this illness. And they would be partial resolution of such shadows at an early stage, and some of the shadows, especially if it is fibrosis, would take little longer time to resolve. So unless the patient has clinical deterioration, it may not be indicated to keep doing. However, if the shadows are ground glass opacification, these are the ones which can be re-evaluated if the patient's clinical symptoms or hypoxia are persisting by doing a repeat CT scan. Post-discharge, normally it would be recommended if the patient has moderate to severe illness clinically, and at the end of 28 days, if the patient still continues to be breathless, would be one indication to redo the CT scan, or maybe over a period of 3 months, we can follow up these patients, especially if they are on anti-fibrotic drugs. Then maybe, like I have already shared you one of the preceding X-ray, which probably was done, like patient came to us in the June, discharge in the June with fibrosis. So now September is the time when actually it has shown resolution. So almost 3 months we did not do much because symptom score itself is good enough, and pulmonary rehabilitation that the patient is complying with a regular follow-up with the clinician, that is good enough to actually decide about the subsequent CT scan. As of now, there is no specific guideline as to which particular time the CT scan should be taken up for this patient, but it has to be again clinician's decision on that individual case.
So, sir, I'm coming down to last few questions to all of you. My important last questions to Pankaj now. Pankaj, what will be your take-home messages and suggestions to patient in the post-COVID phase?
Post-COVID phase is now emerging thing, post-COVID syndrome. Now we are understanding that COVID is not a 14-day disease. It's much more than that. And these patients have shown chronic fatigue syndrome. These patients have shown disproportionate tachycardia even after from recovering from acute illness. Post-traumatic stress disorder, PTSD, has been shown, and all these may lead to another cardiac event. So definitely there is a role of counseling, there is a role of low-dose beta blocker or sinus node inhibitor like ivabradine to treat the disproportionate tachycardia in this patient. And definitely there is a role of cardiac rehabilitation in this patient. So these patients need to rehabilitate gradually to routine. There should not be a sudden jump to a routine, normal routine after the acute phase of COVID. They need to give time to adjust, and that is a message basically. Another thing which I want to tell is that 3 early signs to watch for in a patients with COVID comorbidity. I think this is a message which I want to give. 3 things. One is tachycardia. Second is if the 6-minute walk test is abnormal, that is 6 minute walk determines the respiratory reserve in the patient. So abnormal 6-minute walk test, tachycardia, and third is abnormal cardiac enzymes. These are the warning signals. How much stable is the patient? How much asymptomatic is the patient? If one of these 3 things is abnormal, we need to keep watch on this patient. And if if we watch this high risk patient, definitely we can reduce mortality in a patient with cardiac comorbidity.
Yeah, yeah. Dr. Ambulkar, what will be your take-home message pertaining to diabetes and endocrine management in these patients? Sir, volume, sir. Sir, volume.
I think you manage your blood sugar the way that they are normal. Normal blood sugar is 100 and post meal is 140 when you are at home. That is the way a blood sugar should be managed. Blood sugar in blood pressure in diabetic should be 130/80. Blood sugar, the cholesterol should be less than 200. LDL less than 100 or 70. Maintain your creatinine less than 1.4. Microglobin less than 30. It's a game of numbers. Democracy is a game of numbers. So diabetes care is also a game of numbers. If the patient is able to manage these numbers, if the creatinine is normal, microalbumin is less than 30 milligram, all numbers, if he is able to manage these numbers, then diabetes will live for 100 years, provided God is willing to do so. That's what I feel.
Yeah.
Keep on walking more, avoid tobacco and alcohol if you can.
Yeah. Dr. Jetli, I see you tired now. It's almost 3 a.m.
Thank you very much, sir. Thank you.
Yeah.
Thank you
So
very much, sir.
before we leave, your take-home messages for our participants. Can you say something on that?
Well, one of the things that I like to say is I think you guys are doing a great job in continuing this medical education. Despite that everything is shut down, and now through this virtual space, we are all still able to participate. I'm precisely exactly that's what I am doing myself, hunkered down and staying safe. The fact is that we have to wait eventually till things start to open. New York has started to do some elective procedures. I don't know if Nagpur is doing any elective procedures as such right now, but I believe right now it's a hot spot, and that's where most of the even private hospitals have become COVID hospitals, I was told.
Yes.
So none of them are really admitting any other. So what is really now going to happen, I believe, is all the conditions that you and we were all treating pre-COVID, all those things are piling up in the back burners, in the back seat. And those patients are only turning more sour. I hate to say that, but that's the way they are happening. Because what's happening is the cancer patients, they're not getting the chemotherapies in time. Patients are not getting operated in time. They're not getting their imaging testing in time. Likewise with the cardiovascular patients who are scheduled to have bypasses, the elective stents or what have you, none of them are really, sort of coming in. Plus there is an apprehension. If you were to look at it from the patient's point of view, there's an apprehension. They don't want to go to the hospital because they think it's a COVID hospital or the COVID is still hanging around there, even though there is no COVID case right now in New York City. Can you imagine, as we speak, there is not a single COVID case in the hospital right now. So which is an amazing thing that the governors and the managements have done here. So that's remarkable. We are keeping our fingers crossed though, because what's happening is the flu season is just about to begin. We are in the autumn now, and winter is closing in the next couple of months. And therefore, we have to be very cognizant about that. Australia reported, by the way, first time ever, if they can recall in the history, that they have a lowest flu season. And the reason is because it's the same mechanisms people are following their prophylaxis by, social distancing, masks, and hand washing, etc., and sanitizing themselves. So the same rule applied there for the flu. So that's a good sign the chances are we will not run into the flu epidemic, which will only complement and worsen the COVID pandemic, which is still existing. But it does not mean that one should not take the flu vaccine, because that's another thing that people are still saying, that you should still go back to your doctors and go and take a flu vaccine wherever it's indicated, wherever, especially in the COPDers, especially in the asthmatic patients, the heart failure, the elderly. These patients are very, very, prone for flu. And in fact, 60 to 90,000 patients die in the United States alone every year from flu. And nobody talks about it, but it's very, very important to understand that that is an annual incidence, not only just in the United States, but elsewhere. People are dying as well in the rest of the globe. So it's very important that we still take the same precautions. So the chances of contracting flu, if we are approaching with all these guidelines that are the preventive guidelines that are being offered, the incidence will be low, but still doesn't get you off the hook. You should still go and take the flu vaccine. And last but not the least, I would like to quickly comment upon, how interestingly, I think Dr. Sunil and Dr. Ravindra, both they really, and Pankaj of course has been, I've been talking about Pankaj all through the presentation. All three of you have really done a great job in giving out the intricacies of the comorbidities in your fields, and it is something very, very, learning for me, because I always tell my children and now my grandchildren that learning never ends. So we continue to learn through this, and we are still learning through this epidemic every hour, every day. And the guidelines are constantly changing and updating, both by the FDA and by the CDC. So believe in the government, believe in the guidelines, believe in what's being shown, and that is very important for the general public. I know we panelists, we are always advocating it, and we are actually practicing it, but we want to make sure that our general audience, which may be students, residents, fellows, etc., whoever is in the audience right now, I think the numbers are falling, by the way. I think they're heading out for their lunch, perhaps there. So, but the fact is that it is so important for us to really inculcate that habit, at least for now, till the pandemic is fully eradicated.
Yeah. Dr. Sarnaik, your take-home messages to our bronchial asthma, COPD, ILD patients, and how can they protect themselves from this COVID? And also a word on influenza and pneumococcal vaccine, please.
Yeah, in fact, part of this has been thought of. See, the initial impact of this illness can be well controlled in COPD, asthma as a comorbidity by continuing with their regular treatment for every individual patient. Nowadays, because of lockdown and there's so many issues, sometimes the drugs are not available. It is advisable that the patient would stop this treatment at least for a month. And as and when they have any shortage, they should call for the medicines, because as you understand, missing asthma medication can exacerbate the illness in a very short span. At the same time, the disadvantage of stopping the inhaled corticosteroid to rebuild the anti-inflammatory effect of the inhaled steroid takes pretty long time, at least 2 weeks to 3 weeks. So this, all patients should understand that there shouldn't be any intervals or stoppage of medication during this. At the same time, the vaccination, every individual case with COPD who has been requiring either was having exacerbation, hospitalization in past, or those who are having moderate to severe COPD, elderly population more than 65, should be taking pneumococcal vaccines if they have not taken earlier. Influenza, as you understand, they would be every year, they will require to take preventive vaccination as per the protocol or whatever the patient has been doing. But at the same time, if they have not done it earlier, this particular season, it is always safer and better that they will control their illness by proper individual vaccination thereof. But as a take-home message, I will like to add here, COVID and oxygen is the sort of a debate, or like early morning, anybody wakes up these days since last 6 months. First is many of them are checking for their oxygen saturation even during normal phase. And of course, whoever goes to the hospital, they are advised for X-ray and radiologically. So I'll just like to add a very important message where we all should take this back home and keep this in mind. See, what we have been taught all throughout, that the oxygen in very high quantity when inhaled can cause oxygen toxicity itself. And this is just to recapitulate the radiological shadows, COVID, and our understanding. If you look at the left-hand side, this is a single individual who had a rapid onset honeycombing fibrosis, continuously breathing patient, and of course he was not breathless at the time of presentation. So what I mean to say, the COVID will have, it's an enigma. Time only will tell us how it affects or what is the pathogenesis or pathophysiology or long-term sequelae. But one should understand that individual case, the CT scan, the investigation has to be tailor-made. Just to educate us on that, this is the CT scan to highlight. Beyond that, on the right-hand side is an X-ray of an individual who presented with COVID pneumonia, and he required high flow oxygen. And within 6 hours of non-invasive ventilation, this is called as patient's self-induced lung injury. So this is basically what has happened. The radiological shadows within 5 hours of high flow oxygen and non-invasive ventilator. This is a classical example of oxygen-induced lung injury. So this has been now consensus in our own, like entire country. We have our own various forums where we have been interacting with various challenges of COVID. And what has been noticed is if we leave these patients with high flow oxygen for weeks together just to avoid intubation, possibly this is the sequelae of oxygen toxicity, which possibly shouldn't be overlooked in an individual patient. So a timely intervention of looking for an acute lung injury, at the same time timely intubating this patient as it's a sort of not as scary a picture as it was projected somewhere in March, April. And of course, judiciously weaning these patients in right time might reduce the ongoing acute lung injury, especially toxicity of oxygen. So this is a very variable kind of presentation. These are just 2 cases where we need to really have a good understanding of the impact of respiratory physiology, comorbidity, and of course, COVID, the insult of COVID oncoming in the current epidemic. Thank you.
I want to tell you, I'm not just tired, I'm also hungry right now.
So you can have your midnight snack now. Thank you anyways.
No, I need a full lunch like you guys are going to go ahead and have.
So thank you so much, all of you. It was an honor to be moderator of this session. For the further proceedings, I request our coordinator, Dr. Sachin Ghate, to please propose a formal vote of thanks.
Hello, everyone. It was a very nice and very informative session on behalf of IMA. I thankful to all the speakers, Dr. Pankaj Harkud, Dr. Sunil Ambulkar sir, Dr. Sarnaik sir, and none other than Dr. Sharat Jetli sir, all the way from New York, and midnight session for him. So I thank you all, and I also thankful to all the participants as well as organizer IMA and the conductor DG Shield, Mr. Dipen. Thank you very much for giving us a really good session on COVID. Thank you.
Next time, Sachin, send me a round trip. I'll come in person there and do it with you.
Yeah, definitely.
Yeah. Okay. Good night, sir. Good night, Dr. Jetli sir, and all of you can have your lunch. Thank you. Good night.
Happy Valentine's, sir.
More of such interactions. Great. Thank you so much for the opportunity. Appreciate it. Bye-bye.
Happy Valentine.
Bye. Thank you.
Thank you very much.